Allow me to reintroduce myself and the organization I'm working with real shortly. My name is Benedikt Janny. As Carl mentioned, I'm a senior usability engineer for many years, and I'm currently responsible for the usability engineering and user research department at Using. What is Using? Using is a service provider specializing in human factors and usability engineering for especially the medtech and the pharma product manufacturers scene. So me and my team offer expert reviews, UI designs, prototyping, use-related risk analysis, and comprehensive usability testing services. Therefore, we are running state-of-the-art usability labs equipped with simulated use environments, including operating tables, hospital beds, various peripheral medical devices, and our labs usually feature observation rooms with one-way mirrors, and we provide worldwide video and audio streaming capabilities, which almost also leads us to today's topic. And therefore, we are conducting formative and summative usability tests, and we are about to learn what that means in detail. So I'm based in Stuttgart, Germany, but to fulfill our customers' needs, we conduct usability and user research activities in Germany and together with our partners in the US and China. And this leads us to today's topic, a global view on medical usability engineering. So what I want you guys to learn within the next probably 30 minutes, let's take a look at today's agenda. For those of you who are not specifically familiar with the concept of usability, I want to give you a very brief introduction to the topic. Then I want to give you an overview of international regulatory aspects before we really dive into the similarities and differences of relevant international human factors and usability engineering standards and guidelines. And of course, by the end, we want to take some time to answer your questions. So let's take it step by step. To warm you up, I have like a really small usability challenge for you, starting with something. This is not directly medical device related. So spontaneously, from your guts, which of these cameras do you think has the best usability? If you're able to, I would love to have you posting a number in the chat, and we will take just a few seconds for that. From the top of your head, you see those 3 products, which has the best usability. Great, we see some activities here, a lot of ones coming up. A 3 also. Okay, so if we take a look at the crowd, the majority goes for 3. Okay, here we've got an interesting comment. It depends. And number 1 again. So while you're thinking, so we have like a strong number 1 focus here. I want to add some context for you. So the first user I want to present is 5-year-old Mary. She lives with her parents, and since her daddy is a journalist, she loves to play journalist and take photos of her parents and cuddly toys. I've got a second user of cameras for you, which is Chris, a professional photographer specialized in the rich and famous. To get the perfect photo, he often has to wait outside in the cold when it's dark or when it's raining, or he has to take photos out of a car, or when it's going really crazy, sitting on the back seat of his motorbike. And yeah, last but not least, the third user I want to introduce to you is May. May loves to travel the world and take photo and selfies of her and her boyfriend. And you might already notice where I'm heading. So we had this very good comment here. It depends. Actually, now I want to present to you the theoretical definition of usability. And by definition, usability is the extent to which a system can be used by specific users to achieve specific goals with safety, effectiveness, efficiency, and satisfaction. in a specific context of use. So I totally agree with that answer of you, Nathan. I would also say when I'm asked which of those devices has the best usability, it depends. So usability is all about the context of use, and we may never forget that we are not the users. And of course, as you all know, the most interesting context of use, the most interesting use environments we find in the medical world, especially in the medical device world. Um, there's a lot of complexity and challenges in our context of use, and therefore medical devices must perform reliably under various conditions, often critical and high pressure situations. And if that was not enough, we have the cultural aspect. Um, because apart from the use of medical devices, it is also like highly influencing our cultural aspects. Different regions and countries have unique practices or workflows, resources that healthcare professionals may use, and also user expectations that must be considered during design and usability evaluations. So to yeah take a closer look at those international differences or similarities, I want to first give you a better understanding of the worldwide medical usability engineering processes and expectations. So let's dive into the regulatory structure of medical device development. Regulatory requirements vary widely across different countries and regions, but basically all follow the following structure, as you can see here. There's an outer ring of first level regulations broken down into second level regulations, which are then supported and explained by guidelines and standards. And to take it from there, I have one example from my background here back in Europe. From the European perspective, one of the first level regulation is the medical device regulation, like 2017745, better known as MDR, that some of you might have heard. So it defines the requirements of the economic area we are in, so the European Union right here, in the context of medical device development. On the second level, the MDR is implemented by the different European member states using national laws. So in Germany, it goes by the wonderful name of the Medizinprodukterecht-Durchführungsgesetz, yeah, MPDG. You know, we Germans are famous for our short and nice sounding titles. However, neither the MDR nor the MPDG really explain you what exactly to do to fulfill the mentioned requirements, the ones that are mentioned in the MDR. So this is done by a third level, which consists of guidelines and standards. So talking about usability engineering in the medical context, the guideline or standard is called IEC 62366. Yeah, there are several other guidelines, of course, that address the second level or the first level regulation, like the 14971 for risk management, for example. But today we focus on the usability engineering guidelines. So besides the previously mentioned IEC 62366 standards, there are more international standards and guidelines that help us to fulfill the human factors and usability engineering requirements. The most relevant one from my perspective are the IEC 62366/1, the FDA guidance, of course, since the US market is the biggest market still for medical devices. And since the Brexit, we've got the MHRA guidance, so from Great Britain, and there has been a lot of activity recently. We've got the Chinese NMPA guidance. And those four worlds I want to address within the next minutes, giving you details, insights about the process. So we have several guidelines. But despite regional differences, there are commonalities in guidelines and standards across the globe. So all of them basically follow a basic structure which is similar. All require us to first understand the users and the context of use. Then you must always define and specify your user interface requirements. So we have a first link into user requirements engineering. Like for all aspects of medical device development, risk management is key. So of course we have that link to the use-related risk. And therefore we must control use-related risk by identifying our known use problems and conduct a use-related risk analysis. So all of them require us to do so. Of course, we then must design our user interfaces and perform formative evaluations accompanying product development. Finally, we must conduct summative validation or human factors validation, how it's called in various parts of the world, mostly done in form of a usability test, and prepare a summary describing all usability related activities for our design history file. Keep in mind that this is not a linear, but an iterative process, so it goes in loops, which does not necessarily follow to predefined orders, but is subject to change. So there, I also don't want to lay out numbers here. You cannot say like this is number 2, number 3, number 4. At least I would recommend all of you to start with the specification of the context of use, the user research activity, and I think like the end is also defined, but there can be sideways different loops within the process. So now I want to dig a little bit into the details of each guideline. So we have this basic structure, the basic process that all of them have in common. But now let's jump into details. Medical devices to be marketed in the European Union and Japan and several other countries are required to apply to the standards published by the International Electrotechnical Commission, the so-called IEC. It is a global organization that prepares and publishes international standards, basically for all electrical or electronic and related technologies. The relevant release for the medical usability engineering consists of a standard document that is the IEC 62366-1 titled Application of Usability Engineering to Medical Devices. And there's a supplemental document, the technical report called IEC TR for technical report 62366-2, which is titled Guidance on the Application of Usability Engineering to Medical Devices. Basically, the supplemental document gives you further information regarding the different phases and aspects that are laid down in the -1 standard. And I want to keep you in mind and note that this standard mostly goes by the term of usability engineering. As you might have noted, I use like human factors and usability engineering since some regions of the world use either one or the other term, but for our understanding, I think they're basically the same. And sorry for not mentioning this earlier. We had like a question, maybe I can note that one. There was Harry asking on more information about formative and summative usability. We might go back a little. Formative, to make it easy, usability evaluation is evaluation that happens while you're designing and developing your user interfaces still. So accompanying the product development process. Summative usability testing or validation is like the final validation of your user interfaces to make sure that they are safe to use and effective in use. So safe and effective final proof is happening in the summative usability evaluation, and formative is like ongoing process while designing, trying to improve your user interfaces. And I hope that clarifies it a little bit. Okay, and of course, like the IEC standard also gives information and notes about formative and summative testing, as they call it. And yeah, regarding the MDR, medical devices are classified according to classification rules in the Annex 8. The products are divided into 4 classes that you might know. So we have class 1, class 2A, class 2B, class 3, with class 3 being the highest risk class. And according to, and this is important because there are various guidelines and standards have like different opinions on that, but according to the 62366, all medical devices, including class 1 devices, are subject to usability engineering activities. However, the extent and depth of these activities can be tailored based on the risk associated with the device's use, and also a little bit depending on the user groups and user profiles who are using those problems. Let's talk a little about the standards expectations regarding summative evaluation, because for most people this is always very interesting and important. So in the European Union, verification of compliance with the usability requirements is mostly carried out by notified bodies. Like here in Germany, we have TÜV or we have the DEKRA, and TÜV is also like acting internationally. Since there's no exact specification regarding the number of test persons to be used for summative evaluation in this standard, the number of test subjects selected can be justified individually, strongly depending on the user group to be tested with. And yeah, it is interesting to be noted that the IEC 62366, in contrast to other guidelines, do not lay down like specific numbers. However, there are references to other guidelines and studies to studies that other guidelines also reference. But it must be said, it really strongly depends on the type of user group, the associated risk, or even the amount of formative activities that you have performed before coming to the summative part throughout your whole product development process. I personally, but this is, as mentioned before, not written down in the standard, I've seen a range from 5 to 15 users per user group within those summative validation tests, according to the IEC standard. Okay, so this was like the first deep dive of the IEC standard. Let's come to the second one. So as mentioned before, since the Brexit, the regulatory framework for medical devices in Great Britain is governed by the Medicines and Healthcare Products Regulatory Agency, so MHRA. The MHRA released a guidance titled Guidance on Applying Human Factors and Usability Engineering to Medical Devices, including drug devices, combination products in Great Britain. So this is a first interesting hint, because not all guidelines are clear on that, but here it states clearly that drug device combination products are addressed by this guideline. And the latest update was released in January 2021, which is currently version 2.0. You can download it free on the internet. Despite the IEC guide, this is like a free guideline. And yeah, let's jump a little bit going into details of the British guidance. According to the guidance, human factors and usability engineering activities should be applied to all medical devices, regardless of the classification. So this is something that this guidance has in common with the IEC standard. However, the extent and depth of these activities also can be tailored based on the risk associated with the device's use. And expectations regarding summative evaluation of the MHRA. I would say in comparison, as mentioned before, to the IEC standard, there's a clear standard statement here in the MHRA guidance regarding the expected number of test participants. So it clearly says for summative testing, they highly recommend 15 of each user group. So interesting to be noted. Here they are really close to the FDA guidance. But before we come to the FDA guidance, I want to come to the Chinese guidance. And as I mentioned before, there was a lot of activity lately because I think due to the pandemic, the NMPA postponed the release or the final discussion of the drafts a little. And yeah, the final release took place on March the 19th, so hardly 2 months ago. And yeah, it was released, this final version of the guidance pertaining to the application of human factors in usability engineering. The release consists of 2 guidelines. A first document titled Guideline of Usability Engineering Review for Medical Devices, and a second supplemental document, Application Notes on the Guideline of Usability Engineering Review for Medical Devices. Note that these titles are, of course, translated like into English, so they are not the official titles, and my Mandarin is not very good. So, but of course, due to the importance of the Chinese market, there has been a lot of attention being drawn to this release, and a lot of discussions lately going on within the medical usability engineering scene. So let's dig a little deeper into these Chinese expectations. The medical devices in China are classified into 3 classes based on their risk level. So we have class 1, low risk, subject to general controls mostly. Yeah. We have class 2, which applies to a moderate risk, which is subject to stricter regulatory controls, and class 3, the high risk class, subject to most stringent regulatory controls. And according to the guidelines on usability engineering, the usability activities are not mandated for all medical devices of all classes. This is interesting to be noted according to this guideline. The guidelines focus on class 2 and class 3 medical devices. These are mentioned in the guideline. For class 2 and class 3 devices, manufacturers must integrate usability engineering throughout the design and development stages and validate the user interface to, of course, mitigate use-related risks, as all guidelines ask us to do. The NMPA guidelines might be applicable to combination products. And you remember what I mentioned with the MHRA guideline, the British guideline. Here it says like clearly the guideline applies to drug-related combination products. This is not so clear here in this guideline, but there is like 2 chapters on that. And what is mentioned is that it's depending mainly on the primary mode of action. So you have to decide, is it like a device-led or a drug-led combination product? And depending on that, if it's like the primary mode of action indicating that's a device-led medical device or combination product, sorry, then the Center for Medical Device Evaluation is in charge. If it's like a more drug-led combination product that comes out of your primary mode of action analysis, the Center for Drug Evaluation is in charge. And the thing is that this guideline was released and created by the Center for Medical Device Evaluation, the CMDE, the Chinese CMDE, as part of the NMPA. So just device-led combination products could be like more or less specifically mentioned that this guideline applies for. Okay, so I hope that was clear a little bit. Let's dig deeper into the Chinese guidance. So the expected extent of usability engineering activities and documentation depends basically on three parameters. So first, we have the use-related risk level, asking if the device is a high use risk device. For your interest, there's a list of high use risk device categories in Annex 2 of the supplemental document, so the second document of the guidelines I presented to you. So the risk level, the use risk level is the first parameter to tailor your usability engineering activity. The second is the device maturity. Also interesting because it's quite unique for this guideline. So you have to ask yourself, is it a mature or a new device? Meaning, are there predecessor products on the Chinese market yet? And finally, the device nationality is a third thing. This is not like really unique for the Chinese guideline. The FDA has something similar, but you have to ask yourself, is it a national or an imported device? So the guideline reasons that there might be differences between China and other countries. For example, regarding user groups, languages, use environments, etc. And those differences, according to the guidelines opinion, could affect the safe or effective use, talking about an imported product in China. So for the summative usability testing, you have to decide or reason first, are there like similarities or differences in the use of the product in comparison to Chinese hospital or OR workflows? So summative usability testing needs to be carried out in China with Chinese residents unless you can show that difference do not have significant impact on the use. So regarding formative evaluation, the guideline states that the number of participants in formative usability testing is typically set at 5 to 8 people per user group. And regarding the summative evaluation, it clearly states that there should not be less than 15 per user group within the summative evaluation usability tests. And also an interesting side note, which is explicitly mentioned, it must be noted that the usability test team who is conducting those summative usability tests must be experienced and knowledgeable in human factors and usability engineering. So as we might have seen in the past, that we have like design engineers that got like the usability testing as a side job that could be difficult with the new NMPA guideline here. Okay, so these were like really in a nutshell. Of course, there's a lot of information here. In my opinion, the most important particularities of the Chinese guidance. And last but not least, of course, we have the FDA. So in the US, of course, the FDA is in charge, for the validation tests, and the FDA Center for Devices and Radiological Health, the CDRH, is the specific branch responsible for overseeing the safety, efficacy, and quality of medical devices. While we have the Center for Drug Evaluation and Research, the CDER, is mostly responsible for combination products. So in comparison to the IEC, the FDA mainly uses the term human factors engineering, as I mentioned before, and they hardly never use usability engineering. But as mentioned, it's basically the same for us. Let's dig into the details. The most important CDRH release is the guidance document titled Applying Human Factors and Usability Engineering to Medical Devices. It was released in February 2016 and provides detailed recommendations for the human factors engineering process. And recently, we had the release of a second document in December 2022. It's a draft guidance titled Content of Human Factors Information in Medical Device Marketing Submissions, and it aims to clarify that human factors data should be included in pre-market submissions to streamline the review process and enhance device usability and safety. So these are the CDRH documents focusing on medical devices. For some of you guys, we have the world of drug-related combination products or combination products in general. Therefore, we have a release of various documents from the CDER, as mentioned before. And yeah, we don't have the time, unfortunately, to dig into details, but I listed for you guys the most important releases right here. And I recommend you to study them in detail if you are in charge of developing combination products for the American market, since there are some specialities regarding usability, evaluation, and testing. Yeah, to sum it up, the FDA expectations regarding summative evaluation, or as they call it in the guidance, human factors validation, are that the users of each user group to be tested within the summative usability testing should, like with the MHRA guidance, the British one, or the Chinese NMPA guidance, should not be less than 15 test subjects of users per user group. They are all talking about the same numbers. The guidance also reasons here, like the Chinese do, that there could be differences regarding user groups, languages, education also of healthcare professionals, use environments, so that safe use of an important product in the US might not be guaranteed. And of course, sorry for the typo here. This has to say US. So please don't think that it has something to do with China. So same rationale here going for the FDA. And this basically leads us to the fact that for most cases, it's important to conduct those usability tests in the US with US residents. The guideline states that exceptions to this policy are considered, but on a case-by-case basis, and will be based on sound rationale that considers the relevant differences. So you can write rationales, but be specific on this and have like good arguments. Okay, so thank you for following me on this really deep dive, digging into the different guidelines. I want to wrap it up for you guys real briefly. After deep diving into the different standards and guidelines, I personally want you to take back home the following information. So please consider usability as an added value and not just a regulatory obligation. Our common goal must be to build not only safe and effective, but also efficient and satisfying products that improve people's life. Therefore, all guidelines follow this common basic structure of the human factors and usability engineering process. Nevertheless, and I hope this became clear, there are differences regarding extent and national specifics. Major differences are due to differences in the classification systems and based on the assumption that national specifics could have a significant impact on the user-device interaction, languages, user environments, and so on. At this point, I also just want to give you a short disclaimer. I want to stress that I do not speak on behalf of the IEC or the FDA, the MHRA, or the NMPA. Therefore, the information presented, of course, is non-binding. Have in mind that also these guidelines most of the time are not like formal standards, but guideline documents. But of course, they represent the expectation of those organizations. I myself personally am sharing here knowledge based on my experience in a variety of medical device usability engineering projects for different manufacturers. But please note that the standards and guidelines are regularly revised and they are also subject to change. So be up to date. Yeah, for those of you who want to learn more, just a short side note. So there is an online training from us from using in English and in German. You can find further information on the link here at using use-ing.de/use-ing-academy. And yeah, of course, if you have further questions, I would love to dig into details right now. And if there are questions coming up in the future, follow me on LinkedIn, get in touch with me, write me a DM, and I will be glad to help you with all regarding usability engineering. Thank you guys for the attention, and we will see if there are some questions.
Yeah, there are questions right away. So Hari asking here about sampling guidelines. Sampling, how you select a number of samples that you need to do or number of tests you need to do, kind of relates a little bit to having this number of users that you need to have in certain countries. Is there something like a sampling guideline for tests when it comes to usability?
I know that if you compare it like to technical validation tests, then we have like quite strict sampling guidelines. Since the usability validation works like with different rules, there is not such things as like a strict sampling guideline. But as I mentioned before, every guideline requires us to create something like a use specification to understand the user, performing user research. And the deliverable of this phase is this use specification document, which specifies which users are allowed and representative for the summative testings. So you basically define yourself a sampling guideline for the final test samples, the users that we then recruit and perform the summative tests with. I hope this addresses the question a little bit.
Yeah, it was interesting to see how different countries requires different sets of or different numbers of people participating and where they need to be from. And this clearly highlights that if you want to go to Brazil or Australia or somewhere else, you should double check this and not make assumptions that what works here also works from them. I also, of course, clearly missed the Swiss perspective in your international study, so I demand to the next time that you include Switzerland. But
sorry.
apart from that, then, okay, say that I mean, if you want to sell a product in the United States, you clearly need to plan well ahead because it takes time to get hold of users for usability study. It's not something that you write on Twitter to get them. It takes planning, it takes time. But apart from that, would you also recommend to adapt the summative evaluation protocols themselves to adapt to the cultural context and to the country in which you perform them, or can you use the same protocol as long as you adhere to the number of people and their nationality in your studies?
That's a good point. Most of the times, you're almost forced to do at least like add-ons or adapt them a little bit, since you're performing usability studies with a test leader, a moderator, who is giving like tasks to the tested user. And those tasks, first of all, have to be presented in the mother tongue of that user. And as we all know, from different terms and terminologies, we might have to use different words. So these moderator guidelines at least have to be updated, and they are usually annexes or parts of the test protocols. Apart from that, it could also be that different critical tasks exist in one or the other country. So it could be depending on the workflow in the US, in contrast the workflow in Switzerland, there are some critical tasks due to the fact that the education or the healthcare professional is educated different in the US, and we don't test certain test tasks in the US that we would have been testing in Switzerland. So that always be aware that there could and should be updates to your test protocol in different countries.
All right. And do you have anything to say about this number 15? Is that an arbitrary number, or does it have statistical significance?
Like this number 15 comes from a study of Faulkner. Like most of the guidelines reference a paper from Faulkner. If you dig deep into this paper, you will realize that this study was performed not even with some kind of medical product or medical device. So there's a lot of discussion going on right now regarding this number 15. And you see more and more that the guidelines open up a little bit for rationals. If you reason it well, you could also walk away from that number 15. But still, it depends on the guideline. The FDA is quite strict on that. The IAC is quite loose on that. So yeah, I think there will be some updates in the future because like the number 15 is not clearly reasoned. It depends a little bit on the statistics, on the curve that you will also see in this publication. But the question is, does that really adapt to the medical world? And a lot of discussion going on there.
Oh,
But to be safe, go for the 15. That's what I have to say.
Yeah. And I guess it's easy to find the first 10 and super hard to find the last 5. Exactly. But anyway, I mean, do you want to comment on that? In China, they say you should do it on Chinese people being 1 billion people, and I'm sure that they are not all alike. And in the United States, they have 350 million people or 300 million people, certainly not all alike. Are you concerned about that?
That is like my personal opinion. I personally am a little concerned about the question, do we like mix up politics a little bit in those guidelines, or step by step does it become a little more political? Because like from a Chinese perspective, I can understand if the FDA says, no, we want US residents and we want 15, that China says, okay, we want the same thing. Is that like statistically, scientifically speaking, correct? I don't know. I really cannot say I don't know, but there's a lot of discussion going on in the standard committees. I can say this is what it is right now. And since the NMPA standard is really quite fresh, it will be interesting to observe how things are done in China, how strict, those rules of 15 people and 15 Chinese people are treated in the reviews and the audits. Will be interesting to follow.
How did you get hold of translations of those documents?
So fortunately, I've got like a good network and close people of mine who are like mother tongue speaking Mandarin. So this is like the first source. The second thing is that we had like good and big discussions in the national standard committees. And third layer is like for personal use, always good old friend, the AI, but you have to be careful with the AI, as we heard like previously. Yeah. And in these guidelines, it's really about details and could be about terms. So we should rely on like a personal mother tongue speakers here.
Yeah, we had a speaker a couple of years ago talking about getting a software approved in China, and we debated then heavily, is having a native language speaker in your organization like a tacit requirement that you need a Chinese person if you want to sell stuff in China, just because the documents aren't available in the language that you speak, and in order to contact the agencies in the right way, you benefit hugely from having a Chinese native speaking in your organization. Would you care to comment on that?
Yeah, as I mentioned maybe in the beginning, so I mentioned that we are also performing tests in China and activities, but to be clear on that, only with partners. So right now, of course, if you're like a European or US organizations, you could go for yourself, but in China, it's quite difficult to organize everything on yourself. There are certain rules, like official certifications that you should have, and so on. It's always better and easier to go with partners, especially in China. I think most important right now in the world. In Europe and the US, things go a little different, and rules are a little loose there.
Yeah. I was also told, at least when it comes to software requirements and how to get that approved, that China, when they release a new version of a document, there is no grace period. It's like they can release new versions whenever they want, and they effective immediately. This new version is a new one, and then you might need to, you have worked on one version, and then bang, you have a new version in your face, and you need to change everything. No grace period. So they really play tough over there.
Yeah, and you better have like one ear on the street all the time. So
yeah, that sounds really cool. To be continued. Thank you very much, Benedikt, for joining me. Always
thank
a pleasure.
you for having me.
For those of you who are interested in knowing more about human factors engineering and usability, have excellent courses. I also think that you can meet up with them. I see you are going to be in Stuttgart. Is that correct?
Exactly.
Are you exhibiting?
This time not, but I will be at Maytag Live also in the upcoming exhibition. So if anyone is out there, I would be happy to meet with you guys. So also in person and have a chat on usability.